NASA guy David Markarian here, inventor of the DynaROM. Giving you a little background on the DynaROM tool now that the insurers are paying so well. If you haven't seen that, please contact us. We'll tell you all about it. Anyhow, at the top half of the graph in the DynaROM, you can see we have a little picture showing a person moving, so you can see that it's a motion test. Why? Muscle guarding is the body's natural response to pain and joint restriction in motion. And that's why we look at the DynaROM. That's why it works so much better, because it tells you not just the endpoint value. It's not a snapshot. It's actually providing you with the physiological response to the motion and what it elicits. So in the top half, we're looking at the blue line is the left lumbar, the red line is the right lumbar. And this is over time. So this is a patient moving into flexion. There's an increase in activity, decrease in deflection, increase and decrease when they return to neutral, significantly more than what it takes to first bend forward. The electrodes are attached to the low back. Now at the bottom half of the graph, what are we doing differently? We are providing you with the endpoint range of motion, but we're giving you much better information. Why? We're graphing the motion itself, so we can tell the slope, we can tell how quickly they're bending into the motion, and the slope tells us essentially how quickly they're moving, how much restriction there is, how difficult and how painful it is. So the more the slope is bent downward, the more difficult it is for them to move. The more straight up and down, the easier it is. And you'll see most normals move something like this, but straight up and down pretty much. And we're also able to see by the perturbations in the graph, the quality of motion and the response to pain. It's essentially the ratcheting. You can see ratcheting that'll occur with abnormals on the way up and also at the end. And that's because they're not able to move in a smooth way. So that smoothness tells you quality of motion as well. So what we see here is that, again, when a person bends into flexion, normal is for the muscles to shut off completely, almost completely. Why? Because the body's hanging off the ligaments and connective tissue once you hit about 40 degrees of flexion. And that's called the flexion relaxation response. Flexion relaxation. All right, that's what this is supposed to be. Now, when you see, also you can see range of motions, 78 degrees, 44 degrees over here. And what you're able to see is in the muscle activity that this patient experiences significant muscle guarding in flexion. You can see there's high activity. This is called a lack of flexion relaxation. Flexion relaxation. That correlates very highly with pain, spinal disorders, various things in motion. So this is a very well-studied phenomenon. So this tells us we've got an abnormal, and at least 50%, no, 70% of the time, we'll see normal range of motion, which is almost as normal, with the abnormal muscle guarding. That's why this is better to establish if there's injury or not than just range of motion on its own and just muscle activity on its own. The combination is what is great. So the other thing we look at is the slope. And that's you can see that in normal, the slope is relatively straight up and down. And you can see in the patient, there's two phenomena here. One, we see this perturbations. This is that ratcheting that occurs when they go into this motion, flexion. And then you can see the slope. It's not terrible, but it shows that they have difficulty bending into this motion. Now you also can see in the muscle activity perturbations as well. That's called, in the needle EMG world, fasciculation, right? What does that correlate with? That correlates with pain also. If there's significant pain, there's going to be significant fasciculations. It's amazing how powerful this is when presented to anyone, from a jury to judges to mediators. It's incredibly powerful. It's visual, and for some reason, everybody understands it. And a lot of other people that have been trained to look at, and the reason is truly because they're trained to look for static values. We see CTs, we see MRIs, everything is static. And, does it hurt lying down, getting an MRI done? Does it hurt when you try to bend? That's why we use the DynaROM. Thank you and happy scanning.